Hi, Jamie Raymond here with our hip abductor protocol. This protocol started years ago with an observation. The observation was that I could influence hip abductor muscle firing with ankle manipulation. Later on, I had the opportunity to put this to a test in the form of a clinical research trial. So based on the results of this study, we're able to say that in those patients with a past history of ankle sprain, a unilateral hip abductor weakness, that ankle joint manipulation helps to improve abductor force production and activation. Adding to the results of our trial, I can tell you that clinically, if you have an ankle joint that's subluxated enough to be causing abductor inhibition, you're also going to have soft tissue deficits as well in the form of a mobility issue, in the form of restriction, adhesions, or a stability issue in the form of weakness from the past injury. In the real world, you have to address these soft tissue findings as well. It's not enough, unfortunately, just to adjust the ankle and say, okay, we're good. And that's what this protocol is all about, is putting together the evidence with the real world application and bringing it all together to get your patients better.
So before the first video, let's start with a quick overview. All of our protocols follow the same basic sequence or flow, starting with manual muscle testing using one or more often a combination of muscle tests to identify the region of the body where dysfunction is located, in this case the ankle. Next, while we know from our hip abductor study that it is ankle joint complex subluxation that causes the actual inhibition, we're going to evaluate and treat any ankle soft tissue mobility deficits first. So we'll do a round of IASTM and pin and stretch techniques to the ankle before adjusting it. This has the benefit of facilitating your adjustments and allowing for bigger and easier cavitations. After the soft tissue work, then we will adjust. Next, a brief round of trigger point release using the 6 out of 10 test to help confirm that you've been successful in your adjusting and that the muscles surrounding the hip abductors are now going to be receptive to further muscle work. Then, a round of rehab, looking at the muscle imbalances, in this case not only to the hip abductors, but also looking for any underlying strength and stability deficits in the ankle. Finally, one extra S for synergists, often your local pain generators, basically the muscles that have been compensating for the abductor inhibition and may likely be in need of further release. To help memorize the flow, I use the acronym Mr. Spats, famous for his 21 hats, with an extra S. All right, so let's get started with muscle testing.
So the first step of the hip abductor protocol is to make sure that the hip flexors are testing strong. If they're weak, it's going to skew your results with your abductors. The anterior glute medius and TFL contribute to a lot of flexion, so if the hip flexors are weak, you're not going to get an accurate test on TFL. So for the psoas, we want to bring the legs straight up. The key is to, as always, to have them keep the knee locked. I'll tap it a few times, right up until I test it, so keep your knee locked, please. Push straight up. Good, and that feels pretty strong. Obviously, you can overpower them if you want to, as you have a leverage advantage. So that's not the point. It's just looking to see whether they can respond to an adequate measure of force. Now, if that was weak, that's going to point to a dysfunction up around the psoas attachment, thoracolumbar, lower back area. By this stage of the protocol, hopefully we've already addressed that, so you're ready to move on to the abductors. So the next step, now that you know that psoas is testing strong and that your hip abductor test is going to be accurate, is to do the abductor test. So we're going to do it in the TFL position, even though we know it's more likely to be anterior glute med. Again, make sure the knee stays locked. I'll tap it again a few times, add a little bit of internal rotation, keep that knee locked, and then push straight out. And I'll kind of point to them where they should be pushing. Push straight out. Yeah, and that's pretty clearly weak. So at this stage, based on the fact that psoas is testing strong, TFL is testing weak, the only thing we know for sure is that there is an ankle subluxation, and it could be one of four things: subtalar joint, talocrural, or proximal or distal fibula. So we're going to focus on the mobility aspect first and do some motion palpation to establish where the subluxations are. As always, if you have a joint subluxated enough to be causing a muscle inhibition, there's almost always going to be an accompanying soft tissue deficit, whether it's mobility or stability. So in this case, we've established that there's restriction laterally. So I'm going to do my soft tissue work first. I'm going to do it anyways. So if I do it first, it usually allows for bigger and easier adjustments. So for talus, I like to use kind of a shearing motion. Get one hand on the malleolus, stabilize, the other hand on the talus, and just shear, looking for range. Maybe drop down to the navicular. For the calcaneus, just kind of inversion, eversion, looking for glide. Especially with the calcaneus, it's always good to compare sides. You might think this side feels okay, and then you palpate the other side and realize that, well, that actually is moving better. In his case, it feels pretty good. Then we go over to the lateral side. The fourth metatarsal can be a cue, so I kind of watch his face, and he's grimacing, and it feels pretty locked up there. So the fourth met is your clue that there's restriction laterally, in addition, obviously, to the fibula itself. And again, he's kind of grimacing, and it feels pretty tight in there. So we're going to go with fibula and lateral ankle as our restrictions. So we're going to scrape the ATF. He has a history of some ankle sprains going back as far as college. So we're going to do ATF right underneath the malleolus, peroneals. I usually don't go all the way up to peroneus longus, usually stick with the brevis. That tends to be where the adhesions are. And indeed, he's pretty crunchy here. So I'll do about 5 or 10 passes per area. And if you did feel the restriction on the medial side, which is frequently the case, you might hit the deltoid ligament. I usually don't scrape posterior to the malleolus. It tends to be quite tender through here with the tendons and the Tom, Dick, and Harry. So I'll stick to the anterior side of that. As with a lot of regions, I usually start with the IASTM first, and it kind of saves your hands, saves your thumbs, helps you find the adhesions more quickly, and then based on the findings of the IASTM, then I'll go and do some active release or whatever soft tissue technique you prefer or certified in. He wasn't particularly tight medially, but if he was, again, people frequently are, just pin and stretch the deltoid ligaments. Typically, the medial ligaments are shortened, almost holding the ankle in inversion after ankle sprains. So I don't spend a lot of time ARTing the lateral ligaments because they're already likely stretched out. So I won't do a lot of ART on the ATF. I will scrape it, but maybe not a lot of ART there. I will, however, do ART on the peroneals, especially the brevis. And again, you have a lot of adhesions there, so I would expect that to be tight. For the peroneals, especially the brevis, we'll go into plantar flexion and inversion. So I'll ask them to kind of pull their foot up and in towards the floor. A lot of times I'll use my hip to establish the tension, and so I can use 2 hands. And just kind of find where's the tightest. So now the fun part, we get to adjust the ankle. I'm going to set up the contacts on the right ankle just so the camera can see better. So for the lateral side, I use 1 of 2 contacts. If I really want to isolate the fibula, I'll use ipsilateral, so my right hand to his right leg, thumb contact on the malleolus, and then reinforce that with my other hand. Or if I want to try to target multiple joints on the lateral side, I'll maybe bring my thumb down a bit underneath the malleolus onto the talus, and then reinforce that. If the restriction was more on the medial side, and there's no rule it can't be medial and lateral, in his case it's lateral, but if it was on the medial side, I'll use right hand on left leg or contralateral, sneak down to the talus, and again reinforce. The actual impulse looks the same for all of these, it's just your hand contacts and placement that differs. So we'll do a real-time adjustment here. He definitely had a lot of fibular involvement, so I'm going to try first the second contact where I'm getting the talus And I'm going to use my opposite hand to grasp the malleolus. Try to keep my back straight. I do a little waggle to make sure he's relaxed. And voila. So oftentimes with that adjustment you'll get multiple cavitations. I got one. I got a pretty good release out of the fibula. But I know there's going to be a little bit more than that. So I'm going to come down and I'm going to get the talus. And I'm also going to get the fourth metatarsal, which we established was stuck earlier. I was just informed I was not keeping my back straight. I'm going to try a little harder on that. And a little release there. And just to be mean, I'm going to snap the MTP also. And his calcaneus actually felt pretty good, but we'll pretend that it was restricted. Most commonly it's kind of stuck in inversion. So that setup looks like kind of grasping the calcaneus with contralateral hand, pulling it into some eversion, reinforcing that with the opposite hand, and thrusting through it. And so finally, the proximal fibular joint. We'll use, I don't know what this is called, but I think this is a pretty standard adjustment a lot of people do with the thenar behind the fibula. I always ask, make sure that this feels okay. Does this create any knee pain? No. If somebody has lateral meniscus or especially tight quad, that can create some pain, and you could hurt somebody that way. So I always make sure that it feels okay. Add a little bit of external rotation. Use your chest to kind of deliver the impulse. All right, so I feel pretty good about the ankle releases I got, and now it's time to retest the abductors. Make sure that you are objective about this. Don't have any wishful thinking that you're hoping it's stronger. You gotta be objective. So keep that knee locked, just like we did the first time. Push straight out to the side. Good. And if there's any question, recheck, do it one more time. Okay, great. So that pretty clearly feels stronger. So I'm confident that we got enough released in the ankle. So one final step to ensure that you got everything released is we're going to do some trigger point work, a 6 out of 10 test on TFL of the glutes. And same idea, if something has not let go yet, this will tell us. So Spencer, tell me if we get to a 6 out of 10 if I press into here. Yep. So TFL is a pretty usual suspect. The anterior fibers of the glute med are what are inhibited. And so everything around that, including TFL, tends to compensate, and that's generally where you get trigger points. So let me know if that improves by half.
Yeah, that's good.
And again, I'll do that 2, maybe 3 times. Tell me if we get back to a 6. And again, I phrase it as tell me if it releases, don't say when it releases. You don't want to create the expectation that it's going to release. You want to know if it does or doesn't.
That's good.
Good, so it should, if you've gotten everything released, that should let go within about 10 or 15 seconds. If it clearly won't let go, chances are you've missed something, fibula, ankle. There are a couple other possibilities too relating to the back. And in our full protocol, we'll have all those differentials laid out for you. So we've established that there's ankle subluxation, ankle restriction. There's a mobility deficit, but we also want to look at the strength and stability of the ankle to see if there's a weakness there. So as part of our ankle screen, we'll start with just a basic balance test. So Spencer, let's have you stand on your right foot. We'll stand on the good side first and bring your other leg out to the side. So just have him abduct the other leg. That challenges the inverters and everters of the affected side. So that's the good side. It looks pretty stable. That's good. Now try this side. Make sure they don't externally rotate the foot. They're going to tend to want to do that. He's not, but oftentimes they will externally rotate the foot. Yep. So this side looks mildly weaker. Spencer's a pretty fit guy. He's a pretty high volume runner, and his injury isn't that bad. I'm not expecting to find a significant discrepancy, but we're looking for even subtle differences can matter. So his balance on the floor at least looked pretty good. It looked like a subtle difference. We're going to maybe try to quantify that a little bit more by adding some instability in the form of a balance board. So let's do the same thing. Spencer, stand on your right foot right in the middle. And so again, this is his unaffected side, and that looks pretty good. And then why don't you step off and step back on with your left foot. Again, make sure he doesn't externally rotate. And there we go. So it took the addition of the balance board, but the discrepancy is more obvious now. So the balance test is purely about balance. We're also going to add a single-legged squat, which gives you a little bit more information. It incorporates balance, but also intrinsic strength, tib posterior, peroneal strength, kind of puts everything together with the addition of, get to watch how the knee's tracking. So it gives you a lot more information. Normally I wouldn't be here, I'd be standing demonstrating it for him, but I'll be here. So go ahead and try the single-legged squat off your right foot, Spence. So again, always start with the good side. So we're looking at his ankle for wobbliness. We're looking for supination or pronation. And we're watching how the knee tracks and what the hips are doing. So that looks pretty good. Now let's do this side. And so his ankle is a little more wobbly, a little bit extra pronation there. That indicates tib posterior weakness, and that's the most common finding usually. Peroneal's less commonly. And his hip's having a hard time stabilizing. So that tells us there's likely some tib posterior weakness. There's a balance discrepancy, and those are two different things. I've come to realize that intrinsic strength and balance are two separate issues, and they can be independent of each other or coexist, like in his case. And then obviously the hip abductor, we got that turned back on. It's not immediately going to be fully strong, and that just sets the stage for rehab to now be effective. So he still has some work to put in, but the first stage is getting the muscle turned back on.
Okay, so as far as glute med strength, understand that your ankle work is what will alleviate the glute med inhibition, but it is also frequently just plain weak, even when patients have been attempting to work it. When any muscle is inhibited, the body pretty quickly learns how to work around this by recruiting neighboring synergists. So even if they have been doing appropriate exercises, the glute med oftentimes just hasn't been responding, and you need an exercise that specifically isolates it in such a way that the patient can literally feel the difference. Oftentimes there is a tendency to pile on additional harder exercise progressions, especially if the patient isn't responding, but in these cases you may only be perpetuating the imbalance. It's often better to find one or two moves that break down the imbalance to the simplest, most basic level the patient can feel. I learned this firsthand. I sprained my ankle several times as far back as high school, and this inhibition was affecting my hip into my 30s and 40s despite doing banded monster walks for years. The exercise that helped me the most, and what I often prescribe, are clamshells, banded clamshells. But with the addition of putting the thumb right on the muscle, what I call clamshells with intent, you're trying to initiate the lift from where your thumb is. I tell patients you don't want to feel the fatigue elsewhere, for instance lower down in the piriformis or down lower in the IT band. It helps not to lift very high. She's actually lifting too high for a beginning progression. The only problem with these preformed band loops is that you often don't achieve tension until you're well up into abduction. You really want tension as soon as you start to lift, so I'll frequently give patients my own little TheraBand loop that I've tied. It's also helpful to have them compare sides. I know in my case I could literally palpate less muscle mass on my affected side. Another option is side-lying leg lift. Same idea, have the thumb right on the glute, have them keep the leg a little bit posterior, and a little bit of internal rotation seems to isolate it the best. And then once they've spent enough time with these exercises and evened out the imbalance, you can then progress to harder versions if desired. Although for many athletes, these exercises combined with a barefoot single-legged squat will be enough to maintain strength. So if you find a tib posterior weakness, I normally start people off with just a simple alphabet. Again, simple exercise, but if it's done correctly, it is pretty effective. And for a lot of people, the alphabet combined with a single-legged squat is enough to rehab the ankle. Make sure that they suspend the foot, draw nice big slow letters with full ankle range of motion. You want them all the way into dorsiflexion, all the way into plantar flexion. Have them draw from the MTP joint, pretend the tip of the pen is here, not the big toe. So you're not working the toe flexors as much as tib posterior. Obviously, you can progress on to banded exercises. I know when I was recovering from my ankle injury, I would often just sit and cross my leg and use my hand to push my ankle into eversion and create an eccentric load on the muscle, which is pretty effective also. So peroneal weakness, I believe, is actually less common than tib posterior weakness despite its reputation. If you look in the literature, peroneal activation deficits after ankle injuries, sometimes it's present, sometimes it's not, and that's what I see in patients. Sometimes weakness is there, sometimes it's not. I feel like I'm more likely to find tib posterior weakness in accompanying overpronation versus oversupination. But if you do find peroneal weakness, again, you can start off with the alphabet. In this case, you'd want to emphasize drawing the letters this way. So for the right foot, you draw the letters normally for peroneal weakness. For tib posterior weakness with the right foot, you'd actually draw the letters backwards. So a B would be like this. And with peroneal weakness, a B would be normal to emphasize inversion or eversion, depending on what you're looking for. And then again, obviously, you can progress to a banded exercise. So here's a quick checklist for your rehab. Start with a single-legged balance, a single-legged squat, which will help determine what strengthening exercises they need. Pretty much everybody in this situation needs some glute med isolation. I mean, every athlete should be doing clamshells or banded walks of some form, but if they have glute med inhibition, it's better to start them with an isolating exercise. And then depending on what you see with a single-legged squat, you might throw in tib posterior, peroneals, and I don't know if you're going to see this functionally, but maybe give them some towel pickups for the toe flexors also. So the final step of our protocol is to look at releasing the muscles that have been compensating for the abductor inhibition. Frequently, these synergists are the actual pain generators. These are why patients come in our door. Nobody comes in saying, hey, my glute's turned off. Rather, they come in saying, hey, my IT band is so tight I can't run more than 5K. Well, you may wonder why, if this is the case, why is this step towards the end of our protocol? Well, that's kind of the whole point. Frequently, when a patient isn't getting the results they're looking for, it's because the provider has spent too much time focusing on these compensating synergists and not enough time looking at the underlying dysfunctions. The crazy thing is, and something that I see over and over, is when you follow the protocol, after several treatments where you've worked on the ankle a few times, they've started their rehab, and by now the abductors are no longer inhibited. By the time you reach this step, they're already 50 to 90% improved before you even touch their IT band or whatever their complaint is. This really illustrates how much the inhibition is driving the compensation, driving the injury. So this step is often just a finishing touch. In any case, the usual suspects include QL, maybe showing up as low back pain, TFL, kind of anterior or lateral hip pain, glute min and piriformis, posterior hip pain, or just as likely to be a referred pain into the thigh. Vastus lateralis may be showing up as a patellar tracking issue, and of course the IT band. For what it's worth, at this step, this stage, I'm usually thinking of lengthening techniques like ART. These tissues are frequently truly shortened and need to be lengthened. With the exception of long-term chronic cases, there aren't necessarily going to be a lot of adhesions requiring IASTM. If anything, I'm more likely to be scraping the ankle in these types of cases. So that's the full protocol. I know that's a lot of information, and like any new treatment, it takes a while to integrate this into your flow. But I highly suggest you try it, particularly in patients with recurring hip, thigh, or knee pain. If there is ankle involvement, it really works like a charm. My suggestion would be you start with the muscle testing. It's not quite as simple as it seems. It takes some skill. to get it right, to be objective with it. But if you can identify those patients where psoas is testing strong, but they're weak in the TFL position, that's your clue that there's ankle dysfunction. And in these patients, this protocol will really shine. Independently, you can practice the skills of motion palpating to identify where the subluxations in the ankle are, scraping those surrounding tissues, pin and stretch accordingly based on what you find with your motion palpation and scraping. With the adjusting, the keys are the hand contacts and getting the timing down with your legs, which is a little different than most adjusting we do. But when you get it and that adjustment goes and they now test strong, it's really like magic. 6 out of 10 is pretty easy and also pretty easy to overlook, but it is an important step just to make sure that the hip abductors have responded and are now in a state that they're willing to let go, so that your further release and rehab efforts will work, and you can integrate the rehab as you see fit. All right, so that's the full protocol. I know this may seem like a lot of information, but once you learn the individual steps, it's really pretty straightforward. The hardest part with any new info sometimes is just integrating it into your existing routines. But it's worth learning. For patients with an underlying ankle issue, factoring into a low back, hip, or lower extremity complaint, it works really well. Some final thoughts. Muscle testing is a skill. It takes practice. You'll be basing a lot of your clinical decisions on the results, so you want to make sure you get it right. One thing I didn't specifically state in the video is what happens in a situation where the TFL position tests strong. Well, if it's the first treatment and they're testing strong, not weak, this makes it much less likely that the ankle is a driving factor in their injury, meaning this protocol doesn't necessarily apply. Consequently, there likely is dysfunction elsewhere in the body driving the injury, and in our full protocol, you learn how to combine individual protocols to help track it down. The keys for the soft tissue work are to know your ankle anatomy and to using motion palpation to help isolate the mobility deficit. The key for adjusting are the hand contacts and getting your timing down with your legs. The 6 out of 10 test is pretty easy, but also easy to overlook. It is an important step to help confirm that your adjustments worked and that the muscles adjacent to the glute medius are now in a state where they're willing to let go. The rehab is important, obviously. No amount of ankle soft tissue work or adjusting is going to sustain if they have a weak foot. And finally, the final step, releasing the Synergist. Again, the key is to get all of the other steps in line first, and then working the soft tissue adjacent or local to the complaint will be significantly more effective. As far as how much of this you can get through in a session, I find I can pretty comfortably get through the whole protocol in a 30-minute treatment session. If you allot shorter treatment time, you'll just have to break it down into chunks. As always, thanks for watching. If you haven't already, check out some of our other videos, including the hip abductor study, for more details on that. If you have any questions, feel free to post them. I'd love to stimulate a dialogue on what you think, and what your thoughts are, and questions or concerns. Till then, take care.